recording? Okay, hit it, go. You're good.
So we have to do Rocky Mountain at some point, and since it is such an important thing, even though we don't see very much of it around here, all people do travel. And a couple of years ago, I had a homegrown case of Rocky Mountain here, so it's not impossible to get it here. And it's such an important one to go through that I thought we might as well do it now, and then the next sessions we'll get back to Lyme and the other stages of Lyme that we haven't covered. But I really think we just ought to get through this one earlier rather than later. So,
if I remember correctly, Mona, who's on with us, actually had a case of Rocky Mountain spotted fever in her clinic.
oh, is that right?
So Mona, if you want to pipe in at all, go ahead and throw something in the chat box if you've got relevant information for us.
So let's go back just to the first one again real quick. It's all right.
No.
So Dermacenter, the dog tick is what you see there. And I really wanted to show you at least what rickettsia looks like under the microscope. It likes blood vessels, and that's sort of its claim to fame. It's these little pink things are in the blood vessel walls, which is part of the pathophysiology of Rocky Mountain spotted fever that makes it so much more virulent than some of the other tick-borne illnesses. Okay, now we can go. Okay. So we want to talk about which pathogens carried by ticks are considered rickettsial organisms, because it's now a rickettsial family, not just Rocky Mountain spotted fever. We want to know what ticks actually carry Rocky Mountain spotted fever, rickettsii. Know the changing epidemiology of rickettsial diseases in general, which is basically what you're seeing here. Tick-borne illnesses are increasing around the United States pretty much everywhere. We want to know the clinical features of Rocky Mountain spotted fever and how to diagnose and treat it. And most importantly in this whole, if you get nothing out of this, but this point, recognize that doxycycline is the drug of choice for all patients with Rocky Mountain spotted fever, including children under the age of 8, of which he will be giving you a little bit more information about that doxy in that age group. Okay. So rickettsial diseases, which ones are rickettsial organisms? So we all know Rocky Mountain spotted fever is Rickettsia rickettsii, but actually Anaplasma is in the rickettsial family, as is even monocytic ehrlichiosis. So there's also Rickettsia parkeri, which we'll talk about in another lecture. So these are in the genus rickettsial organism, and these, by almost all of these, are potentially life-threatening. Not as much as Rocky Mountain spotted fever, which is the highest, but as we've already talked about, anaplasmosis, people do die from that too, and we had a death here last year. And there, before we go along, you see exactly what we just saw in our presentation. You see the morula in the neutrophil, and if it's ehrlichiosis, you see the morula in the monocyte. Okay. So this is the changing epidemiology of the rickettsial organisms in the United States over the past roughly, 15 years or so. And as you can see, everything is spiking up rather than down. And this is happening pretty much wherever these organisms are live. And so if we can go on. And so I really like this slide. I had to show it one more time. Here's a blood vessel with all the rickettsial organisms stuck into the blood vessel walls, which causes a lot of stasis, a lot of thrombosis in the vessel walls, which is a lot of why Rocky Mountain spotted fever is as bad as it is. And if you can imagine that happening in someone's brain, it can be pretty bad. Okay. So these are the organisms that that can carry Rocky Mountain spotted fever. Dermacenter variabilis, the dog tick. And by the way, you're not supposed to be able to recognize ticks. This is just an FYI. Don't worry about trying to memorize what these ticks look like. It's not our job. Just know that where the ticks live, that's really the important thing, is where these ticks are found. We're going to get to that. But this is an FYI, Dermacenter andersoni, the wood tick, Rhizocephalus sanguinus, brown dog tick, and then the Lone Star tick, which is the one they see in North Carolina a lot, I think. Okay. I always wondered, why it's the Lone Star tick and it's in North Carolina, but who knows? So this is where you see it. The wood tick, Dermacenter andersoni on the west coast, and Dermacenter variabilis on the east coast. And so it's a pretty big swath of area. And if you look, we are in that area. It's not like we can't have Rocky Mountain spotted fever up here. We just don't see it as much. So the way they started classifying rickettsial disease changed in 2010, and they gave it a new category, the CDC, spotted fever rickettsiosis, to include not just Rocky Mountain spotted fever, but things like Rickettsia parkeri and the other rickettsial organisms we were talking about. And so part of this is definition, but if you notice, and over the past 20 years, it went from about 500 in the year 2000 to over 6,000 as far as 2017 went. That's a big jump. And there you can see it in graphic form of the steady rise, and it shows no sign of slowing up. So most of just like a lot of the tick-borne illness, it's early spring through late fall, more in the northern states. You can have it year-round in the southern states. Majority of cases occur, this is important, the majority of cases occur in individuals over the age of 40, but the majority of deaths occur in children under 10 years of age because people don't give them doxycycline when they need it. Okay. And so this is, again, another graphical way of showing where the mortality really is. If you look, it's the young children and the people over the age of 70 that are really dying from Rocky Mountain spotted fever. Okay. And so, again, this is just showing the spikes in the seasonality of when you see the most cases. But again, in southern states, you can see it year-round. And here's where it really sort of concentrates. If you notice, we're not in a high incidence area based on this map, but again, it does exist in this area. It also even exists in southern Canada. And so it's interesting to me that New Hampshire seems to have a lot more than Vermont. I don't know why. But as what you might expect, it's sort of the southeast where it really is concentrating, where you see it a lot. Okay, so you're going to hear this like a broken record again, because it's very similar to what you see with any tick-borne illness. So you get symptoms anywhere from 3 to 12 days after the bite of the tick, the incubation period being 3 to 12 days. It's generally an abrupt onset of fever and headache. That's a little different than some of the other ones. Headache is often prominent with this. And because people feel sick enough, they will usually come to the doctor when they get this. But remember that at best, only 50% of people are going to know that they were bitten by a tick. The other 50% will not have any history of having had a tick bite. So in the early point in time, the first 1 to 4 days, again, it's more like a malaria-like illness than a flu-like illness because cough is not prominent. It's fever, headache, nausea, vomiting, anorexia, kind of like the case we just saw. Abdominal pain, just like what we just saw. Muscle aches is a lot of it. And here the rash is important, but it's not infallible. About 90% of people with Rocky Mountain spotted fever will have the rash, but it's not the petechial rash everybody hears about. This is where you really can, I think this is an important point too. Early on, Rocky Mountain spotted fever is not petechial. It is simply a macular pink rash that is not petechial. And that's when you want to diagnose Rocky Mountain spotted fever. You can get periorbital edema and acral edema on the dorsum of the hands and feet as well at this point. So again, it's a high index of suspicion. It is important to think of this because, again, we were all taught to look for petechiae, but that's a late finding. By the time the patient gets a petechial rash, they're already in big trouble, and you have to try to pull them out of the drain at this point. You want to get to them before they are circling the drain. At this point, they're often really sick. They can get cerebral edema, coma, pulmonary edema. They start to get cyanosis of the hands and feet, multi-organ dysfunction, and death. And again, higher in children. Children under the age of 9 account for only 6% of all cases, but 22% of all deaths. And this is what it looks like early. This is when you want to see it. Everybody knows about the hands and feet. You want to catch it early there. Then when you see the petechial rash, they're already really sick. And then you get to the very late stages where the people lose arms and legs if they survive at all. So again, these symptoms are nonspecific, but they do suggest a tick-borne illness. So again, the same things apply. You have to have a reasonable chance of coming in contact with the tick, being in the right area, right exposure, right symptoms. So as far as laboratory findings, thrombocytopenia, mild anemia, white blood cell count can be low, high, or normal. Once again, increased LFTs. Once again, hypernatremia. Increased CPK is one of the things you can see with this, but it's not infallible. And remember, you can start out with completely normal labs. You don't have to have any of these and still have Rocky Mountain spotted fever. And I will also point out that in the presentation we just saw, it was also important that Legionella was in that differential, because guess what? Legionella can look like this too. And that's why Legionella does come up a lot in this same differential. I forgot to mention it, but doxycycline actually treats Legionella. So even if you're missing it and you don't know, doxycycline is a really good Legionella drug, even though it's not advertised for that. So that's another nice thing about doxy. I meant to mention that before. Okay. So again, surprise, surprise, Rocky Mountain spotted fever is a clinical diagnosis. The serologic tests are negative, usually for the first week. And so if you have somebody coming in after 3 to 4 days of having symptoms, you're not going to have positive serology. And by the time you get your positive serology, they could be dead. So if you suspect that it's a tick-borne illness, particularly Rocky Mountain spotted fever, I can't stress enough to start the doxycycline first and ask questions later. You can get the fourfold rise. And again, this is not one where a PCR is going to help you. It's serology. We don't have good PCR for Rocky Mountain spotted fever. You can get biopsies, but most of us around here are not going to get a cutaneous biopsy to diagnose Rocky Mountain spotted fever. And again, that would have to be sent off, and by the time you're going to get it back, if you haven't treated, they may not be here anymore. This is the tick panel Mayo tick-borne testing algorithm. I don't know if we can blow that up any, Ashley.
We cannot.
Darn it, I have it on somewhere else, but I can't remember where I have it.
I think, actually,
You can get to it?
I have it. So, bear with me one
And
moment.
again, I want to thank Jen Beveridge for showing me this for the first time, because it's really nice and I like it a lot. Okay.
This is it, yes.
Yeah.
All right, now if we could blow that up a bit. Okay, so we're going to go back to just like what we always do. So you got to have the geography. And this is what I like about the Mayo panel. It's actually going through exactly what we just do. You get a clinical suspicion of a tick-borne illness based on the patient's presenting symptoms, the time of year, the exposure history.
I'm sorry.
That's all right.
It's,
So
I don't think folks can see what we're looking at just
Oh, they can't?
because it's given me a bit of a problem.
I'll wait a second.
Okay, let me see if I can do this. Cooperate with me here. Bear with me, everyone. Okay, so this is the Mayo Clinic's algorithm.
And we're going to put this on our website. I don't know if we've done that yet, but we're going to put it on our Tickborne website so you guys can see it. Not only because I think it's a nice laboratory thing, but it actually reminds you what you're supposed to be looking for, which is why I really like it. So they give you the sort of the symptoms to look for with a tick-borne illness, and they point out you have to have some way of it being exposed to a tick. And, you know, basically either they know they've had a tick on them or they've got risk to have had a tick on them by outdoor activities, which is what we keep stressing here. And then you have to have the right geography, like we've talked about. You got to know that the tick is in this, you know, this area, like we've talked about. And they even prompt you where the Rocky Mountain spotted fever is most common. But again, go back to that map. And if you go down that algorithm on the left, see, you order the spotted fever group serology. Notice it's not a PCR. And then, like they say, consider empiric treatment. I would say even stronger, always treat empirically while awaiting test results, and don't stop just because the test is negative. So treat. And let's go on the negative side where they say test negative, report as negative. Notice they don't say stop treatment. They just say report it as negative. So I would stress to you, if you had enough suspicion to start the doxycycline, continue the doxycycline unless you have a clear-cut alternative diagnosis. And I mean clear-cut. Let's go to the other side of the panel just for the heck of it.
Sure.
Just to make your life hard.
No problem. I've got it now. We're good.
So the other things you can get are to go to the right side, because again, you're not going to know which one you're dealing with. Here's where you can actually get a PCR for some of the other ones, except for Lyme. The PCR for Lyme is not sensitive. Again, these are blood tests, and if you remember, Lyme's not in the blood very long at all. And that's one of the reasons I think the PCR is so bad for Lyme. But for these other organisms like Anaplasma and Ehrlichia, if you think about it, and Babesia, the organism is literally in the bloodstream. And that's where it infects. It infects white cells if it's Anaplasma. It infects monocytes if it's Ehrlichia, and if it's Babesia, it's in red cells. So that's why I think the PCR is so good for those organisms, because they're in the blood. Okay. And with that, I think we can actually go back.
Okay.
Yes.
Doesn't like to do that.
Okay.
Not ready yet. One sec. Okay.
Okay. Treatment.
Oh, we lost our camera.
Oh.
Made a little owl noise.
I know, did you hear him?
It does sound like an owl. Let's see if we've still got folks on. Everybody see us okay?
Yeah,
Okay.
okay.
All right. We lost our camera for a second, but we are square.
So this is straight from the CDC, just so you guys know where this came from. I should have labeled that on the slide, I'm sorry. So doxycycline is the first-line treatment for adults and children of all ages. If it's adults, it's 100 milligrams every 12 hours. If it's children, it's based on their body weight, like so many things are in children. And it's, again, doxycycline twice a day. And you want to give doxycycline for at least 3 days after they defervesce, the minimum treatment course being 5 to 7 days. And I don't have it in here yet, but I will tell you that although they don't come out and say, give it to pregnant women, there's lots of studies out there that show in pregnancy, if you give doxycycline, the outcomes are better, because your only other option is something like chloramphenicol, which is like ancient and terrible. It doesn't even work very well. So even in pregnancy, I would advise you that if you have a pregnant woman with Rocky Mountain spotted fever, you give doxycycline. Okay, so it's the most effective treatment of all the rickettsial diseases. It should be initiated before you even have, whether or not you have positive serology or not, based on clinical diagnosis. And remember, if you treat based on clinical diagnosis, you're going to prevent people from dying from this. And if afterwards you find, oh, they really do have something else, then you can stop. But if there's any doubt, keep it going. Okay. So this is, do you want to pick up here? Or?
Sure, I can.
All right, I'm going to let Yi Lee, who is our ID pharmacist, talk a little bit about doxycycline and why it's recommended now, even in children under the age of 8.
Yeah. So as Dr. Collins said, doxycycline should be the preferred treatment for all patients, including children under 8 years old. And the reason why a lot of physicians have hesitancy of using doxy is with the teeth staining associated with tetracyclines with patients less than 8 years old. And the teeth staining was actually first came out in 1970, the warning for all tetracycline, and that was more for the older generations, the actual tetracycline that was produced in the 1940s. So they came out with a broad statement in the 70s for all tetracycline, including doxy. But doxy, actually, there are studies that show that short courses, especially for rickettsial disease, there's no evidence that it produces teeth staining. Next slide, please. So again, we really should be using doxycycline for all of these patients. But even with the current evidence, there still is a warning on doxycycline that we shouldn't be using it for patients less than 8 years old. So I think that comes in with when physicians are prescribing doxycyclines in children.
Yeah, and there are pediatricians that, I don't know if the American Academy itself is doing, but there's a lot of push now to get that warning off.
Yes.
Right?
So if you go to the next slide, both the CDC and the American Academy of Pediatrics recommends doxycycline for children less than 8 years old. Now that's for all rickettsial diseases. All right, so again, like Dr. Collins said, if you don't get anything out of today's presentation, just remember doxy is okay for children. All right, the next slide. And this, I think you had shown it in a little different version.
Yeah, exactly.
But they did a, I think it's 2012, they did a national survey where they asked physicians about Rocky Mountain spotted fever and what they would use. So 80% of physicians correctly selected doxy for Rocky Mountain spotted fever in patients greater than 8. However, only 35% of the clinicians correctly selected doxy in patients less than 8 years age. So that's probably what comes in with the increase in mortality in children. So children less than 10 years of age represent only 6% of Rocky Mountain spotted fever cases, but they represent about 22% of deaths. And that you also see the increase in mortality in the ehrlichiosis as well. So again, and we use doxycycline in those cases as well. So it's not just for Rocky Mountain fever and other tick-borne disease, you could use doxy in children. And you should use it, yeah. I think that's all the slides.
Someone asked where are the pediatricians in this meeting. Okay, that's sort of what we had to cover today. Anybody want to add anything or have any comments about this stuff?
Anyone? Unmute yourself, Mona, Diane.
I'm good.
I just have one other comment, Dr. Desmarais. That was a great presentation, and as you can see, what you just went over, these things are so similar that you pointed that out quite well here. Including, I got to give you credit on thinking about Legionella, because it does come in, especially with the hypernatremia and the elevated LFTs, Legionella can look like this too. And that's why I think it's important you guys know Doxy works for that too. I'm beginning to think if I'm stranded somewhere, I want Doxy with me.
Yeah,
right. Dr. Collins.
Yes.
Go ahead. Yes.
I think, just curious, a lot of doctors here question about Rocky Mountain spotted fever. Can we go back to the testing slide? Isn't there a slide about testing?
You can go back to that other one. You got to go back to your other thing now so you can see it.
Oh, we want to do the...
Yeah, we're going to go back to the other picture so you can actually see the algorithm.
Okay. Just in general, a lot of the doctors are getting IG just by getting antibodies. They're just ordering usually an IG labs is what we get most frequently for Rocky Mountain spotted fever. Just to start with, any kind of advices for the follow-up, just to make sure that we are going through when we're taking care of, getting all the labs that we need to. A lot of them are treating right early, which is good news. But as far as labs go, sometimes we don't have sufficient labs to make a case. So
this is what the algorithm from Mayo says, and I think it's good. I don't know if this answers the question, but you get the spotted fever group serology, including IgG and IgM, and you treat. And even if it's negative, they recommend repeating the titers in, they say, 2 to 3 weeks. I kind of keep in my head for just about any of these kind of illness, get another one in 3 to 4 weeks if you want to prove that that's what it was. But again, like a lot of these things, if you treat it soon enough, you may never develop positive serology. It's possible.
True. That's excellent.
Does that answer it?
Definitely.
We will put this on our site. I will talk to Jill Terabullo, who couldn't join us today, our librarian, and we'll get this on the site so you guys can see this too. Okay? I think it's worth having there.
Sounds good. You've got the gift of time again today. Awesome. Vanessa, thank you so much for your presentation. Did a great job.
It was great.
No slides necessary.
Right.
Yeah.
And by the way, no slides ever necessary. Just talk. We're fine with that.
Yeah.
That was just great.
Although your slides were beautiful, Justin. Not to discredit that. It was awesome.
Right. We just didn't let the bar set that high. Exactly. Yeah, that was great too. It really was.
Thanks.
All right. Thanks, everybody. Have a good afternoon.
All right.
Bye.
We'll see you next time.